Good evening. I'm Yi-Chun, a second-year resident at Chang'e Memorial Hospital in Taiwan. Okay, and it's my pleasure to be here online to share our study on the association between atopic dermatitis and migraine. Okay, atopic dermatitis, or AD, is a pretty common inflammatory skin condition. And over the years, studies have linked AD to a variety of comorbidities, including atopic and non-atopic disorders. While migraine is an episodic severe type of headache, typically presenting as a throbbing pain on unilateral head. And some studies have suggested a connection between AD and migraine, possibly based on similar triggers and inflammatory environments. For example, increased levels of Th2 cytokines, which dominates in AD, had also been discovered in migraine. And in addition, during allergic sensitization, mast cells release cytokines that help trigger migraine attacks. So these findings suggest that both AD and migraine may share a common inflammatory pathway, and this overlap really highlights the similarities between these two disorders. However, there is still a lack of comprehensive analysis on the association between AD and migraine. So the objective of our study is to systematically analyze the association between AD and migraine. And we perform a systematic review and meta-analysis of observational studies. A comprehensive search from Medline, Embase, and Cochrane were conducted. Our most recent search was completed on August 18, 2024. We selected studies including case control and cohort studies that assess the association between AD and migraine. And these studies defined AD patients as the case group, people without AD as the control group. The risk of bias was assessed by using a Newcastle or Taiwan scale. A random effect model was adopted for meta-analysis. The outcome measures were pooled odds ratio for included case control studies and pooled hazard ratio for cohort studies. This is the selection process of included studies in our study. We finally included 9 case control studies and 3 cohort studies, with a total of about 15 million subjects. These are the characteristics of the 9 included case control studies. We can see that most of the studies were conducted in the United States. And these are the cohort studies we selected. As the assessment of risk of bias according to Newcastle Ottawa scale, most of the studies are considered high quality. Our meta-analysis showed that in case control studies, patients with AD had significantly higher odds of having migraines. In the cohort studies, we consistently found that people with AD had an increased risk of developing migraine. We also did a subgroup analysis based on the severity of atopic dermatitis. We defined mild AD as patients receiving only topical medications, and severe AD as those receiving immunosuppressants. Subgroup analysis from 9 case control studies found that severe AD had higher odds of having headaches. However, in the cohort studies, the increase in risk for developing migraines among severe AD patients was not statistically significant. This result may be explained by differences in the age groups within the cohort studies. One of the cohort studies showed that in pediatric group, mild AD was actually associated with an increased risk of migraine. However, severe AD was not. And finally, to investigate the association between AD and migraine more specifically, we also conducted a sensitivity analysis. Results show that whether using the specific term migraine or the general term of headache, the significant association with AD remains consistent. And here's the last part. This is our discussion. From this meta-analysis, we found that AD patients are more susceptible to migraine compared to the non-AD population, with increased odds ratio of 1.64 and a hazard ratio of 1.21. The potential mechanism linking AD and migraine may include: first, both disorders had neutral triggering factors. Several allergens such as diet, smoking may activate inflammations that may lead to flare-ups of both AD and migraine. Secondly, there are overlap in the inflammatory responses. A key factor in both conditions is the mast cell. In AD, mast cells drive skin inflammation, while in migraine, mast cells can activate neurons that triggers pain. Also, elevated levels of pro-inflammatory cytokines such as histamine were seen in both disorders. Histamine in particular can prolong the activation of trigeminal neurons, which plays a key role in migraine. Moreover, neuropeptides like CGRP and substance P are known to be key mediators in migraine. These neuropeptides have been also found in the skin lesions of AD. They can trigger the recruitment of Th2 cells and increase the expression of interleukin-4, which was known as a hallmark of immune pathway in AD. And this overlap suggests that these neuropeptides may play a role in linking the inflammatory pathways of both AD and migraine. Last, a recent Mendelian study also showed genetic liability to AD with increased risk of migraine. So to sum up, immune dysfunction, neurogenic inflammation, and common triggering factors and genetic liability may serve as links between AD and migraine. And this is our conclusions. AD is associated with increased risk of migraine, especially in severe AD. The potential mechanism may involve similar triggers and common inflammatory pathway. So based on these findings, it is important for physicians to be aware of headache symptoms in patients with AD and consider early intervention for these patients. And this is the end of my presentation, and thank you all for your attention. And I'm now happy to take any questions. Thank you.
Thank you very much. Thank you very much.